illuminated by lipids. And Gail, how about some light? Everybody up, and I think we have some toothpicks over here if anybody needs them for their eyelids. But we have some cool stuff to talk about, and hopefully we'll have a little bit of fun. It is, and I think there are going to be a lot of light bulbs going on too, so everybody be ready. This is my squeaky clean slide. What I'm hoping to talk about is listed here. There's some cool pharmacology stuff. A little bit on the guidelines. I promise not too heavy there. I think everyone's been guidelines sort of to death. I would like to have time for comments and questions, but I also want to get everybody out of here on time. Before I start talking about familial hypercholesterolemia, I wanted to recognize Dr. Paul Hopkins. None of you know him, nor have I ever met him, but he is a wonderful clinician from the University of Utah who helped to establish the FH Foundation, and he was very generous in his support of me. In fact, shared many of his personal slides with me so that I could share them with you today, and I'm very grateful to him. Familial hypercholesterolemia, or hyperlipidemia, abbreviated as FH, is just a very important clinical entity that I think we don't well understand. And so one of my whole points today is to help us all know exactly what it is. So, okay, it's really high LDL cholesterol. It sounds a little bit simple when you say it that way, but I'm hoping to teach you more caveats about this because it's an extremely important public health issue for our country, basically internationally. It's autosomal dominant, and it has to do with the Ldl cholesterol receptors on the liver. As a friendly reminder, the issue about having the atherosclerotic burden of FH that is really the issue, and it has to do with the lifelong accumulation of not only LDL, but all the ApoB containing lipoprotein particles. That's a whole lot of words, but remember this non-HDL entity at the bottom, which basically includes all the ApoB-containing lipoprotein particles that circulate in our system. Most ApoB rise on LDL, but we also have the very low-density lipoprotein, the intermediate-dense lipoprotein, and the lipoprotein A that are all considered atherogenic. And we get a very good idea of that burden when we measure blood looking at the non-HDL. Gail, do we have a pointer that works?
Yeah, it's on there. It's the top part of it.
How about one that works? Oh, they're good. All right, wasn't pushing hard now. Nice, thank you. This concept of having high cholesterol in youth and increased heart disease as we get older is not new. This is an older study that was published in the early 1990s. It measured cholesterol, total cholesterol, in 22-year-old men and basically followed them for 40 years. And you can see that on the far right side, the red line, 22-year-old guys who had higher cholesterol levels had a significantly higher risk of heart disease later in life. This is not a new concept. How the LDL gets high, I think, is really important, and it's very important for us to understand so we can help our patients to understand. This is kind of a cartoon slide, but the surface of the liver is demonstrated here. I think my finger was in the way, that's the issue. The surface of the liver is here. These little green Ys are actually Ldl receptors located on the surface of the liver. And it's these lipoprotein particles circulating in the blood that are basically taken into the liver via those Ldl receptors and then basically metabolized. So I explain it that way because it's really important as clinicians that we help our patients understand why their LDL is so high, because as you know, people feel very guilty about their cholesterol. They think, oh, I'm just eating the wrong thing, I'm eating too much, I'm not doing enough, when in fact it all has to do with the fact that the condition of familial hyperlipidemia does not, basically these patients don't have LDL receptors on their liver. In fact, they have about half as many as the usual population. And often the LDL receptors they have are functionally impaired. So they just simply don't work to clear the LDL cholesterol from the blood. That's an important concept. Now, there's a lot of research still ongoing about exactly what goes wrong with this condition. Most of the issue is with the mutation on the gene for the LDL receptor itself, probably 85 to 90% of the time. There are over 900 mutations that have already been identified on that particular gene alone, but there are other entities associated with this internalization of the LDL into the liver for degradation that are also at fault in the gene pool. And this one down at the bottom is really interesting. We're going to talk a little more about it later, but Pcsk9 enzyme is also very relevant when it comes to controlling LDL because of the receptor. So it's all about the liver receptor. That is really sort of the main premise behind familial hyperlipidemia and also for a lot of the pharmacology to treat this condition. So again, to state it in a different way, impaired LDL receptor mediated clearance is the underlying issue. So when the LDL isn't cleared from the blood, basically the LDL has extra time in blood vessels. What happens with that is that there are other modalities that can then attract the LDL for degradation in unhealthy ways. And if the hepatic receptors aren't doing their job, scavenger receptors become active. And scavenger receptors actually will not attract LDL unless it's oxidized. So first LDL has to then become oxidized, which is atherogenic. The scavenger receptor captures it, creates foam cells, and it further perpetuates the atherogenic process. So there's all sorts of nastiness that goes along with having too much LDL and a liver that doesn't clear it effectively. This is a very common disorder. 1 in 500 people has heterozygote familial hyperlipidemia. It is the most commonly inherited genetic disorder of metabolism. It's more common than all of these other diseases, even more common than neonatal hypothyroidism, more common than type 1 diabetes. It's very, very common. 1 in 500 are heterozygote for this condition. Now, the homozygote condition is very rare at 1 in a million. I still haven't seen one yet. As I mentioned, this is autosomal dominant. That means when you see a patient in your clinic, you can tell them that you got this from one of your parents, and 50% of your kids will be affected and 50% of your siblings are affected. The unfortunate thing is most people don't know that they have it, and lots of people don't know if their family had high cholesterol. But this is a big deal. Heterozygotes, meaning they have inherited this condition from 1 rather than 2 parents, have a 2 to 3 higher LDL level circulating. So these people frequently present with LDLs in the 200 to 300 range, and the homozygotes are even higher with LDL in the 300 to 600 range. Of course, the big deal is the premature risk of atherosclerosis. And the unfortunate thing is this line down here. Many people don't know they have a condition and don't know it until they present with their first MI. This is kind of an interesting slide, again, sort of demonstrating the same idea about risk. Age is across the x-axis. The y-axis is this cumulative Ldl. This was sort of a fancy mathematical calculation that basically determined a lifetime LDL exposure threshold, at which point people would be susceptible to vascular disease. That line is the second one from the top. You can see that people who are homozygous for familial hyperlipidemia cross that LDL exposure threshold and develop vascular disease in their teenage years. People with a heterozygote formation fare a little bit better. They often don't present until closer to 40 compared to the normal population who crosses that LDL threshold at about the age of 60. Importantly, in people, especially who have the heterozygous FH, other cardiovascular risk factors greatly accelerate the risk of presentation with cardiovascular disease, especially smoking. Smoking, diabetes, hypertension, and gender make a big difference in how early these people present. So I want to show you some of my patients. Michelle is 36. She's a nurse. She's really healthy diet. You can see she's a runner. She runs about 25 miles a week. Her father died at 43 of sudden death, and she was told that he had high cholesterol and thought she should have hers measured. She remembered it being kind of high a while back. Came to me with a total cholesterol of 330, LDL of 244. She's now being treated. She's doing well. She has no evidence of atherosclerosis. So one day she brought one of her two kids in. This is Xavier. He's 11. He is a math whiz. He is on the swim team. He swims 2 to 4 hours a week. They've never had junk food in their house. Here's his cholesterol. He's 11. Okay, you cannot make the diagnosis of familial hyperlipidemia by looking at Pearson, right? He does not look like that, but it's common. The problem is that we're really underdiagnosing this condition. We're capturing about 1/5 of the population who has familial hyperlipidemia, and the ones that we find are not yet being aggressively enough treated. Okay, they often require dual lipid-lowering therapy, and we're missing a big opportunity when we find one index case. We should be performing what's called cascade screening, meaning that 50% of first-degree relatives related to that individual will be afflicted with the same condition and will put them at higher risk for early heart disease. So we really do have an opportunity to make a difference. Sort of awkwardly stuck this statin slide in right here, but the purpose of the slide is to remind us about the pharmacology of statin therapy, because again, it's all about the Ldl receptors. We know that statins basically reduce cholesterol synthesis by impeding this HMG-CoA reductase, so less statin is produced. But the benefit is actually the result of that causes upregulation of the Ldl receptors, so they can do a better job in clearing LDL. So there's this common theme that I'm trying to get through that isn't the easiest to think about, but it's all about really the Ldl receptors. This slide is actually a more colorful version than the earlier one that was talking about that threshold for heart disease. I wanted to show you what it looks like when you add statin therapy into the mix. So the threshold for cumulative LDL lifetime exposure is the green line, and the objective is to get people to cross that threshold later in life. The red line are people who have one gene for familial hyperlipidemia, and comparing age that they would cross this threshold at about 35 if they're untreated. If statin therapy is started earlier in life, they are disease-free much later. And when we use high dose, their disease-free interval approaches people who are not, who do not have FH. So the importance and availability of statin therapy in mitigating cardiovascular disease in this population is quite significant. You have this in your handout, but it's basically the same idea, suggesting that patients with a heterozygote formation will have almost the same MI-free survival benefit as people who do not have this disorder. It's treatable. So how do we make this diagnosis? Well, it's not very hard, but it starts with a blood test. Basically, we generally accept that an LDL cholesterol above 190, some people will say 200 or 220, is very consistent with familial hyperlipidemia. This is generally followed by a positive family history of either very high cholesterol or premature vascular disease. And sometimes there are physical findings that will also suggest this diagnosis, but they don't have to be present. There are other diagnostic criteria, like the Dutch clinic criteria, and a couple of others that are a little bit messy to use, that are used in other countries to make this diagnosis. The gold standard for diagnosing is actually genetic analysis, but that really is only available, is not available in clinic labs. And so we're left with making a diagnosis on, like I said, family history and lipid testing. This is a chart that's included in your packet with emphasis on the third line, basically identifying the with 80% confidence somebody will have FH at a given age with a given LDL cholesterol. That's included for your reference. So it's just basically all about the LDL. I brought a couple slides just as reminders. Remember those pictures we used to see in medical school about high cholesterol? This isn't a very good photo. I apologize, but this is one of my biology professors from Platteville who really was more concerned about this irritating, this annoying xanthelasma around his eyes. We've all seen these. This is probably the most common physical sign of high cholesterol. It's just sort of this waxy deposit around the eyelids. The good news is it actually will go away, but it takes several years of treating their lipids aggressively. He didn't start to get his lipids treated aggressively until his 4-vessel bypass at 42. The arcus senilis is another physical finding. It's that light ring at the periphery. I find this very nonspecific. I don't think I've ever seen it in somebody. And the tendon xanthomas are sort of the classic findings. And these are kind of subtle. Really, you can just see sort of these bumps on the Achilles, a little bit here also on these tendons. Now, these not only are interesting to find, but they're uncommon because they tend to occur later in life. They are the result of, again, this lifelong exposure to high LDL levels. But the presence of them is very important because in addition to the diagnosis of FH, patients who exhibit these physical findings definitely have a worse prognosis and have earlier heart disease. So they're subtle. They're very uncommon to find in children just because they're too young, but they do have a prognostic implication. I wanted to make you aware of an international organization called MedPed, Make an Early Diagnosis to Prevent Early Disease. There's a very nice website, and basically it's a patient registry, it's a patient education resource, and it's a site that has ongoing research trials that people can become enrolled in, and it's an international effort to basically raise awareness of this disorder. Even the AHA has jumped in and put out a scientific statement as of last year, basically reminding us about the condition and emphasizing the importance of an early diagnosis. The reason I wanted to start with talking about familial hyperlipidemia is because it is really the basis of the subsequent guidelines of cholesterol screening in children. They've been a little bit contentious, but if we keep the perspective that the purpose of the guideline development was to identify this particular disease, I think it helps to sort of accept the recommendations a little bit. I think we've all read these studies on, Korean and Vietnam War casualties who had autopsy studies performed that demonstrated atherosclerosis definitely begins in the teenage and 20 years of people who are at risk. There are other studies, both epidemiologic and autopsy, again, suggesting that children who have risk factors are more likely to have early heart disease. And it is from those studies that we know atherosclerosis begins in childhood. So just sort of a pictorial description of that same concept, recognizing that risk factors can be present at birth, especially with familial hyperlipidemia. So the top is, of course, just sort of the progression of atherosclerosis at the level of the intima, pathophysiologically what could go on, and with the ongoing risk factor exposure, that risk increases. But what's really disturbing to me is just the timeline and the reminder that it truly is a chronic and progressive disease that starts much younger than symptoms would ever be apparent. And preventing this progression, I think, really requires early identification of risk factors. So the presence of risk factors, the increased number of risk factors, and the increasing severity of risk factors all increases and accelerates that timeline of progression. So the guidelines, I think these came out in 2012 about how to reduce cardiovascular risk in kids. The NHLBI website actually has this entire document for your reference. Like any good guideline, it was contentious, and other expert bodies disagreed with it. Most recently, the U.S. Preventive Task Force issued an I statement. I didn't even know what an I statement was, and that's when they get through levels A through D of evidence and decide there isn't anything there. They basically claim an I statement, which is a null statement. They don't think there's enough data either way to even weigh in on the issue. I will leave that to your own interpretation when I get through my slide, because I sort of think they dropped the ball on this one. There's also been a little bit of disagreement between the American Academy of Family Physicians and pediatrics, so it's a little hard to keep them all straight, but here's what I got. There's some rationale for why we ought to screen, and really the big picture is trying to find kids that have FH, okay? You can read through these. We know that lowering lipids in adults improves their outcomes. I think one of the unintended consequences actually of screening children is this top line. We're really looking for familial hyperlipidemia, but what we mostly find is the combined familial hyperlipidemia, which are the kids that have a little bit of high cholesterol and a little bit of high triglycerides, which is consistent with obesity, sedentary lifestyle, and insulin resistance. Those are the predominant abnormalities that are now being identified for a screening procedure that was meant to find something else. The good news about the familial hyperlipidemia combined in kids is that making lifestyle changes in those kids, which have to be implemented by family, makes them a whole lot better and reduces their future risk of diabetes. But that wasn't the point in developing the guideline. You can read through those. One of the issues with kids is that we don't have long-term randomized controlled trials. Okay, that's one of the issues that we lack evidence that we wish that we had. We do have some vascular imaging studies that are interesting. I want to show you one. This was a study of kids that had heterozygous familial hyperlipidemia. They measured the insulin-mediated thickness of the carotid, which in many studies has basically been a non-invasive way of recognizing cardiovascular risk, and does correlate, the IMT thickness correlates with heart disease risk. So they looked at kids in the same family who had FH as opposed to their sibling that didn't. And by the age of 12, there was a significant difference in the thickness of the IMT in children who had FH compared to their non-affected siblings, which I thought was interesting. So again, we don't have these long-term studies to know that preventing or that treating versus not treating kids is going to equate with longer life. What we do know is it does equate with that in adults, and that higher LDL lifetime exposure is associated with increased and early disease. So what do these guidelines say? Well, there's like 20 pages of how to interpret the guidelines, and they're much more complicated than the adult guidelines, but the gist of the matter is the recommendation is to screen kids between the ages of 9 and 11. Universal screening, everybody gets a blood test to check cholesterol and non-HDL, which can be done non-fasting in conjunction with their annual physical. That is the recommendation. Those years were selected because at that time in the child's life, and I'm learning all this about kids as an internist, their lipid values are relatively stable and very consistently track what their lipid values will be in adulthood. Between the ages of 11 and 18, it's common for lipid results to actually decline a bit in kids, so we try not to check them. Selective screening is indicated for children who have other comorbidities. Best to look at just the far right-hand column here. These are just some guidelines, and again, the whole document is online and you can find it, but really, children with a non-HDL above 145 is an important cut point for abnormalities. The subtle increases in triglycerides and the subtle decreases in HDL cholesterol have been confusing for clinicians, and I think complicate the nature of the screening process. But I think focusing on either LDL if you have a fasting lipid panel in kids, or the non-HDL are best. I agree with the universal screening as opposed to targeted, which previous guidelines actually had endorsed. We have data suggesting that if we only screen kids who have a history of obesity or a family history of early heart disease, we're missing nearly 50% of children who have high cholesterol. So we screen it, we find it, what do we do about it? Well, diet and lifestyle are very important. It's the children's recommendations are slightly different than the adult guideline, but they both focus on reducing saturated fat, identifying other risk factors and treating them. Must include screening all first-degree relatives. But even if we get all of this right, I always tell patients that, you just don't have enough LDL receptors, and even when you do all these things right, your LDL is still going to give up 200, because it's important for them to understand that. Statin therapy is indicated for children over the age of 10 with familial hyperlipidemia. So again, why are we screening? It's common, it's treatable. When we find one case, we can find many more, and we can have an impact in reducing premature cardiovascular disease. But really, we screen for people like this. This is Allie. She's 12. She's a dancer. She's a little bit sassy. She tells me when she eats French fries. Her maternal grandmother died at 61 of sudden death. Her mother has asymptomatic subclinical vascular disease in her late 30s. Allie has an off-treatment LDL cholesterol of 224. She's on 5 milligrams of simvastatin, and her LDL is 110. We made it. Good effort. Does anybody have any quick questions on FH? Yes.
So how are you managing the combination of family planning women statin?
Oh, that's an excellent question. So statins are contraindicated in pregnancy. So there are 2 ways to manage that. I tell women who have maybe been on a statin who want to start a family that they stop the statin when they stop the birth control. And we just basically don't treat during pregnancy and lactation, and they come back and see me when they're through that time frame. There is the bile acid sequestrations are felt to be safe, but I don't think the value of those drugs is worth worth treating during those years. So it's a good point.
So not much to say, I guess, I'm a pediatrician, so not much to say about we do a lot of screening, we see a lot of cholesterols that are well below 200, but the HDLs are, see a modestly overweight kid or more,
right.
Whose LDL is floating around 35,
Yeah.
his HDL is floating around 35, and his cholesterol is about 150, 160, so he probably got juvenile metabolic syndrome, but he isn't. I mean, that's not familial hypercholesterolemia. Yeah.
Right. So the question is about HDL in kids, and that just drives me nuts.
You can't fix it.
You can't. So, and it really bothers parents because they want every number to be in the perfect range. And if the HDL is 35, it's not a treatable metric for lipids, even in adults. I like to remind people that it might improve with lifestyle improvement, but that is not FH. That is not why we're screening. We're just looking for the LDL. Right.
So what is the influence of lowering lipids in children with FH or heterozygous or homozygous with respect to their maturation? Because we know cholesterol is a precursor for all hormones, especially sex hormones.
Yeah, there is absolutely no. So the question has to do with does treating children with statin therapy impair their normal growth and development? And there has been no study to suggest that it does. These are considered safe starting at the age of 10. Some studies even say 8.
So, thank you.
I'd like to move on because I want to show you the cool pharmacology. We finally have a study on Zetia that I think is worth talking about that came out a couple of years ago called the Improve It trial. This was basically a double-blind randomized control study in ACS patients who received either simvastatin or simvastatin with Zetia, and were followed for many years to see if there was improvement. So the simvastatin alone is in the blue line. Simvastatin plus Zetia, you can see the LDL was significantly lowered by about 17%. So the LDL in the Vytorin patients was about 54 compared to about 70 with the simvastatin alone. This was an event-driven trial. The composite endpoint was statistically significant, showing about a 6% relative risk reduction in patients who were on the combination therapy with number needed to treat at 50. So it was a small benefit, okay? Looking a little bit deeper, it looks like this was a composite endpoint. the real benefit was in the non-fatal MI and stroke prevention, which accounted for most of the benefit. Also important in this was it has finally put to rest any fears about the serious complications that had earlier been attributed to ezetimibe, which were laid to rest. There was no statistically significant difference in any side effect between the simvastatin versus the Vytorin group. This is an important study. This was really the first trial that told us incremental clinical benefit could be gained for our patients when we added a non-statin drug to a statin. So we got that. It seems to further promote the concept that even lower LDL is even better at risk reduction. And thirdly, confirms that Zetia is safe. As an anecdote, I do use Zetia, and I find that in most patients, half dose is as effective as a whole. It only comes in 10 milligrams. 5 milligrams seems to work just as well and saves people money. Speaking of money, I think it is to be generic within the next year. Pcsk9 inhibitors. Okay, if we're not too tired, we can all say Proprotein Convertase subtilissin Pcsk9. This is like the real big deal. Okay, there are 2 drugs currently on the market, alirocumab and evolocumab, and this is an entirely new, sort of revolutionary way to lower LDL cholesterol, and again has to do with the receptors. We know that when there is a gain of function with this particular enzyme, there are fewer LDL receptors available, and vice versa when there's loss of function. Because this is the best way to explain it, in spite of this industry-provided example, I want to show you this very short video clip because it just does a really great job of explaining the pharmacology of this whole new drug class that people are going to be asking you about. You got that? Okay, maybe not. There we go.
The role of Pcsk9 in the regulation of LDL cholesterol. Cholesterol is transported in the blood by lipoprotein particles, of which one major group is low-density lipoprotein, or LDL, an important risk factor for atherosclerotic disease. The liver is the gatekeeper of plasma LDL levels and is responsible for its clearance and catabolism. Hepatocytes express LDL receptors that bind LDL and remove it from the plasma. The Ldl receptor complex is taken up by the hepatocyte in clathrin-coated vesicles. Inside the cell, these vesicles fuse with endosomes, and the acidic environment of the endosomes facilitates the dissociation of the Ldl receptor complex. The Ldl receptor cycles back to the cell surface, where it binds to additional LDL particles, leading to a further reduction in plasma LDL cholesterol. Free LDL and endosomes are transported to lysosomes and degraded into lipids, free fatty acids, and amino acids. Proprotein Convertase subtilissin-like hexin type 9, or Pcsk9, is a protein that regulates the expression of the LDL receptor in the liver. Hepatocytes produce a precursor of Pcsk9 that undergoes self-cleavage in the endoplasmic reticulum and ultimately is secreted into plasma as functional Pcsk9. Extracellular Pcsk9 binds to the LDL receptor on the surface of the hepatocyte and gets internalized with the Ldl receptor complex. Upon dissociation from LDL, the Ldl receptor Pcsk9 complex is routed to the lysosome for degradation, thereby preventing the cycling of LDL receptors back to the cell surface. Thus, Pcsk9 plays a critical role in regulating plasma LDL cholesterol levels by modulating LDL receptor expression on the surface of hepatocytes. Mutations in the human Pcsk9 gene that lead to a loss of Pcsk9 function are found in 1% to 3% of the population. These loss-of-function mutations have been associated with lower plasma LDL cholesterol levels. Hepatic cholesterol levels are regulated both by the rate of intracellular cholesterol biosynthesis and by the expression of cell surface receptors that take up cholesterol from the blood. When hepatic cholesterol levels are depleted due to a low biosynthetic
There we go.
rate,
That's as technical as I can get, really.
Back. Oh, sorry. Here we go again.
So
Get it.
you'll get it. So these drugs are exciting. They're new. They're safe. They're very effective. We're seeing, reported 60% reduction in LDL cholesterol when added to maximally tolerated statin therapy. The negatives about them, the cost, about $1,000 a month. Yeah. Injectable every 2 to 4 weeks. There's just a little pen injection under the skin. That's not a big deal. It's really the cost that will be limiting. Current indications are for patients who have homozygous FH, and again, this is always added on to maximally tolerated statin. It's not instead of statin, okay? And heterozygous FH patients that have various criteria to meet approval. And in patients who have persistently elevated LDL cholesterol, I like this one, who have atherosclerosis but require additional LDL lowering. Nobody's come quite out and said it should be for statin intolerant patients, but we do have some patients who are taking just a micro dose of statin who still have very high LDL, and we worry about that residual risk. So new stuff, we actually have evolocumab on our formulary with prior authorization. And we've had some great help from our colleagues in the specialty pharmacy department at Fish Hatchery. Eric Huggins, thank you very much. So I think more to come. These drugs are safe, they're effective, and outcome studies will be available within the next 2 years, which I'm really excited about. So we are all familiar now with the new cholesterol guidelines that aren't so new anymore. I don't really want to spend too much time. I think you're familiar with them. They're very simple compared to the child. I thought we should kind of take a pause and laugh for 2 seconds about this because it really reminded me about guidelines and why we have them. Recall that the 4 statin benefit groups that have been identified according to these new guidelines are as listed, and certainly this bucket of patients on the very bottom are those who are otherwise healthy people that have a 10-year risk of cardiovascular event above 7.5%. I think that's truly been the most contentious group. It's our primary prevention patients and trying to figure out who would benefit from statin. And it really is an age-related phenomenon. Who hasn't had a really irritated, healthy 60-year-old man in the office with a score of 10% and doesn't want to take a statin? Those are the tough ones. But the reality is, you know what? Vascular disease, it definitely increases with increasing age. As I've been looking at how people have responded to these guidelines, I have noticed a couple of pitfalls that I thought would be just interesting to highlight. This is just my impression. You guys are probably not in any of these pits, but I just thought I'd bring them up. Biggest one is we shouldn't use this calculator in patients who are already taking a statin. Okay, this risk calculator is only meant to help us determine a risk stratification to help us know if a person needs a statin. Okay, so there's no role for it in people already on therapy. We don't know what to do with people over 75. The risk calculator, you can use it, but the cohort that it's compared to does not include people over the age of 75, so it really isn't relevant. It doesn't mean that you shouldn't treat people over the age of 75. It means that this risk calculator doesn't apply to that demographic, okay? Please don't use the risk calculator for patients who have an LDL over 190. We know they're high risk. We don't need more risk calculation. They just need to be treated, okay? And the other thing I still kind of see once in a while is not using a calculator in people who have a high HDL with the assumption that that high HDL is cardioprotective and that the LDL, regardless of its elevation, is not a big deal. So those are sort of some things that I've noticed, and just as by way of reminding folks. I also like to point out that the guidelines are not a replacement for your judgment. They really should just start the conversation with the patient about treatment. Lastly, I'd like to endorse the National Lipid Association, lipid.org, or as I'm called in my department, geek.org. I think this is just a wonderful resource with lots of great education. And that, in fact, I think you wanted to get board certified in clinical lipidology. This is where you go to school, right there. So anyway, so much for illumination late on a Friday. Any last questions? Yeah.
The question is the opposite about low LDL. So when the guidelines came out, it's like, yes, you should have everybody on statins. Do not even recheck if it's not necessary. However, the question remains like, what do you do when you have someone that goes really low? Because we know that having very low LDL could also be different things. So I frequently have patients that have the risk factors, look at the LDL, and the LDL is already like 100 or 90 before statins. So if we start statins by some of the recommendations, because we think that statins are effective anyway, regardless of the LDL, then I always wonder what happens when the LDL goes too low.
So the question is about when to start a statin, and is there an LDL that is too low? And the answer is that really the guidelines, and I commend them for this, are focusing on not so much LDL, but on cardiovascular event risk, okay? And there are plenty of people that have a normal LDL who already have vascular disease. So the benefit of statins goes beyond LDL lowering and has to do with anti-inflammatory effects on the endothelium. So we should get away too much from the LDL and focus on the risk reduction through the drug class. And the second question about how much LDL do we need? Well, the studies on newborns and primates with the vegetarian age suggest that the physiologic LDL is between 30 and 40. That's all we need to be healthy. And so the most recent guidelines suggest if the LDL drops below 40 on therapy, you should probably back down a little bit. Okay, so 40 is a good, and there's very weak data on whether we really have to do that, but that's sort of the answer and why. Yeah.
So take the TCS question in a slightly different direction. The issue of why that, what you just said notwithstanding, why we do annual lipid panels on patients once.
Right, get them on high dose, high potency done, right? High potency statin, high
So we should
dose.
change our health maintenance settings in EPIC to stop prompting us to do unnecessary tests that are not clinically indicated.
Absolutely, absolutely. But the answer to your question, I do have to follow up with is twofold. I think we should recheck them in our highest risk patients, recheck our lipid panel. There's a couple reasons for it. We know that it improves compliance with medication. If you measure it, people are more likely to take it. And the other purpose is, especially in our high-risk patients, some people really are kind of what we call statin under-responders. That you put them on the highest dose and their LDL will go from like 145 to 120. That's not a good response, and it's not very common, but you don't want to miss those people because they have a lot of, they still have a lot of atherogenic risk that needs to be addressed using combination therapy. Those people are usually hyperabsorbers of cholesterol in the gut, and they really respond to the addition of Zetia, which, remember, increases cholesterol absorption at the brushboard or the small intestine. So those are the two reasons that we should follow up on our highest risk patients once they start therapy. And then once you get them to goal, once a year is fine.
Can you give me one or two talking points on all my male patients that don't want their memory damaged by the statins?
Oh, gosh. Yeah, that is like the most common one. Well, you could tell them about the study that says there's an improvement in erectile dysfunction. What do you say? And that's about as anecdotal as the one regarding memory loss. So that, but on a serious serious note, there are observational reports primarily with simvastatin regarding short-term memory. There is no clinically relevant study that has ever supported that. So what I do with patients is recognize that, give them a drug holiday. If they think they get significantly better, I will often put them on hydrophilic statin, like Proprotein or Crestor, as opposed to the lipophilics, because there's less theoretically blood-brain crossing with that drug class. But those are my two secrets.
Do you prescribe CoQ10 for all these patients who are on statins?
The question is about coenzyme Q10, which is ubiquinone, and the answer is, the question is, do I prescribe it to all patients on statin? The answer is no. There is conflicting data about whether or not it's beneficial in reducing statin-associated myalgias. And some studies say, yep, it helps. Others say, nope, it doesn't help at all, but they all say it's safe. And so I don't routinely add it, but I offer it as a way of maybe keeping people on a statin that they really need if they have myalgias, and tell them there's a 50-50 chance it will help them.
I have a series of friends and family members who are statin phobic because of myalgias and the risk for cardiomyopathy. And they're certain they have family members who have died of heart failure because they were on statin.
Oh, thinking that because the heart is a muscle and the statins cause a myopathy, that their heart will die.
Yeah.
Oh, yeah. I haven't heard that one, actually. I think the best, people need to know that the most likely cause of their death in our country is cardiovascular death. It's 50-50 for guys and a little better than that for women over the age of 50. And so I think that putting it in context like that is helpful, and then explaining, of course, the difference between, heart muscle and skeletal muscle. And anybody else have any ideas about how to undo the media hype about the drug class that the media most loves to hate? So, yeah.
If your cholesterol numbers are good, but by age you're supposed to be on it, do you monitor cholesterol once you go on simvastatin or whatever? Is there anything there? If your cholesterol was good to begin with.
It's good to begin with, right. The goal of primary prevention is to reduce the LDL by 30 to 50%. So yes, I do check it.
Even if the cholesterol, if the LDL is like under 100 already.
You're putting me against the wall on that one. I probably would check it, but I appreciate your point, and I'm not sure. I think it could go either way. Thank you so much for all of your attention.